All right. And is my microphone back on? All right. Can you guys hear me? Come through? Great. Just like Bon, I do want to thank everybody here for pulling together an amazing group, and for you guys for coming and being interested along with us in this new kind of evolving idea of how do we bring a design mentality? What could it offer to the way we approach healthcare and medical education? And as Kirsten said, my day job, quote unquote, I'm an academic researcher, associate professor in the Department of Emergency Medicine at UVA, University of Virginia. And what I really do most days is think about the built environment and how it impacts health and well-being. And somewhere along the way, that has me interacting all the time with designers, architects, and so forth. And somewhere along the way, I became really fascinated in what is this. I feel like I know I have benefited greatly as a researcher, as a physician, as somebody trying to make the world a better place by understanding that design mentality and then bringing it into my work. And somewhere along the way, it really was I was inspired by people like Dennis Boyle and people at IDEO who the idea of design thinking came across as the way I looked in on it was, here's a pedagogy or a potential pedagogy that I think I could actually, it captures what I've learned, how I've learned to approach problems from working with designers, and what might happen if I started along, and I'm not the only one asking this question, obviously, what would happen if I started trying to teach design thinking to medical students? And I was given that opportunity at UVA. I've been doing it for a couple of years, and I'm going to tell you a couple of things I've learned. Assuming that somewhere in this group there might be some folks at a more traditional medical center like myself or maybe have a crazy idea of doing this themselves. So we started our medical design program in 2015, and the way we are, as I said, we are not Dell Medical Center, which I'm very envious of. Let me be very clear. But we are a traditional medical school that had to accept those constraints. In other words, what that meant for us is, our program is an elective course that students choose to do above and beyond their normal coursework, and they are first and foremost medical students. So basically, what that means is we have the opportunity to work with them in monthly workshops. So we get to see them about once a month for 4-hour design sprints, essentially. And I usually find out that I can usually ask them to do maybe 3-4 hours of prep work before that. And I've just kind of come to embrace that constraint as something that I think a lot of people would find as their truth. And what we found, I'll just cut right to the chase, is that we've still been able to have a really meaningful experience with that. But the exciting part is it's pretty stable, it seems like. Out of a 120-person class, we typically get about half the class responds to the email saying, I'm interested. About 30 shows up to the information sessions. And we've been able to formally enroll about 15 students each year. And we've now taught, we actually have a growing cohort of these, what we call them fellows, at this point at UVA. Along the way, I've learned a couple lessons. I'm going to tell you just 3 of them. But if you're out there, again, if you're like myself, if you're in a position where you are trying to maybe start this, not necessarily just in a medical school, but in a nursing school, I'm going to give you a couple of lessons that I've learned by doing this. The first one is I've learned as I've been doing this is don't try to sell design thinking. Focus on the changing educational needs of future physicians. And I'm going to be reiterating things that Bon and I'm sure the rest of the speakers are going to talk about. So what do I mean by that? Well, let me just give you my pitch that I now use more frequently when I walk into somebody that I'm trying to convince to let me do something new or more of what I've been doing. What I really genuinely believe is, just like Bon said, the grand challenges of healthcare are really fundamentally changing. My version of that, the things I see, are things like, just in the realm of data and technology. I had this kind of aha moment a while back when I realized the fundamental metaphor of healthcare is still based around an assumption that all of the data produced healthcare data is produced during a physician's physical exam. that's still, when you stand back from it, we still are operating under that assumption. Obviously, here, even in just 2018, with like an Apple Watch, not even to mention, what Dana's, her artificial pancreas, the idea of like that being, that's already not true. And obviously going forward, where personal data come from and the amount of it that is generated is going to become overwhelming. Disruptive discoveries. We truly are, I think, living through discoveries in medicine that are not normal. They're different. They are true inflection points. The ones that rock me a little bit to think about what they're going to mean for medical practice include things like the microbiome, genomics, how those personal health data intersect with those things. Making use of those data and that understanding and turning it into clinical practice is literally going to be beyond the power of a human being. We're going to be interacting with artificial intelligence and so forth. What that means to be a physician in that, I don't know. And anyone pretends that they do, I'm not sure. I'm not sure whether we should believe them. And finally, systems issues. If you chart the real causes of health burden in our society these days, they used to be things like that could be treated with vaccines, things like infectious disease and so forth. Now it's about things like chronic diseases, things like childhood obesity and so forth. These are things that cannot be simply treated. They are, by definition, complex systems issues, and we have to train physicians in a very different way to play a role in addressing those things. And so what kinds of competencies stem from those things? These are really different than the traditional ones we've been training physicians for over 100 years. If you think about those issues, what you need is a future physician who has a mindset and a confidence around being creative, wants to take on and feels comfortable taking on change. You need people who have a systematic approach to innovation. Whether they are going to do it themselves or lead a team or be part of a team. And then finally, you need future physicians that have real-world experience collaborating with highly diverse interdisciplinary teams. These are the new competencies. What I'm telling in my pitch at this moment, everything up to here, you can usually get people's head nodding, like, yeah, absolutely, absolutely. That's exactly right. And we even have national level calls from saying these are the new competencies. The tricky part is, though, medical education hasn't kept pace with that. And I think everyone will accept that, too. If you look at our traditional pedagogies, they really aren't oriented towards these necessary competencies. And this is the first moment that I usually get to introduce design thinking. And again, it's more of like a logical deduction. Like, well, what are the pedagogies out there that do actually land on those exact competencies? What are the ones that are out there? And any Google search will pull up design thinking as one of the predominant pedagogies. And in fact, that's usually when I pull up a fairly recent Harvard Business Review issue, and I always point out to them, note, it is not talking about the new thing, design thinking within business. It is a retrospective on 10 years of teaching design thinking within business schools. And I think, actually, to be completely frank, I use that to my advantage that this isn't all that innovative, is my point. In many ways, actually, healthcare is well behind a lot of other areas, people who have to train people like business students and so forth. And that usually gets a nice chuckle around the room. We're so lame, and that's a great moment where I strike. And I'm like, so don't worry, we're behind, we're late to the game, we're not doing anything scary, I can help. I found it actually sets up an interesting conversation and a deeper conversation about why are we doing this. We're not just seeking novelty. We genuinely are trying to be responsive to the changing needs of the time. So then, actually, what it sets up is I think a more interesting design challenge, which is a challenge. It is literally like, how might we integrate design thinking into medical education? Stacy and I were having a conversation earlier. We are going to have to manage this transition time, right, from kind of healthcare as it is now to a future that I think I'm very excited by, the future that's being dictated and outlined for us by some of these institutions. But managing that change is going to be challenging. and to pretend it isn't and that we don't need to I think that's where I've found myself able to contribute. So, in the spirit of design thinking, I just said, okay, I'm going to set up my experiment. And as always, in my group, I had these incredibly courageous first 15 medical students in 2015 who said yes to this I was very open with them that they were going to be co-designing this experience with us. And we tackled a couple of key issues. Basically, the best way I could think to do it was I had the chief quality officer of UVA open up their door where they list the top true north issues of UVA, and there they were, like 6, intransient, problems, and I said, let's choose 2 and get started. So the ones we took on were inpatient falls. We had some really poignant things come out of this. So they went around the hospital essentially just talking with nurses, occupational therapists, using data from the patient safety teams. Not surprisingly, they found out that at UVA, like almost any hospital, most of the inpatient falls occur as patients who are post-op or things like that get up in the middle of the night and have to try to navigate over to the restroom. So here we are just basically prototype. These tables have been situated to approximate the dimensions of like a hospital room and this young man, Zaid, he had taken care of his grandfather for about 3 years prior, who had had a lot of fall issues, and so he was kind of taking on the role of his grandfather, and we were just doing some really simple empathy exercises. But it turned into quite a robust engagement with some of the patient safety team around UVA. We also took on the issue of high utilizer patients that are have frequent readmissions, and we had the chief hospitalist help whenever one of the high utilizers was admitted. We would then deploy some of our students who had kind of told them their availability, and we asked them, instead of worrying about their inpatient care, we focused explicitly on their out of hospital care, and these students uncovered remarkable. Just taking the time to talk with these patients, they uncovered remarkable new information that UVA actually immediately used, and they actually really centered in on redesigning the discharge instructions as something that could be dramatically improved. And I think it was really thrilling to the students that their actual design that day didn't immediately turn into discharge summaries, but it actually truly did start a major rethink of discharge summaries, particularly for these very special patients. Second year, we took on improving the ER patient experience, which was fun for me. Again, this was particularly poignant just because UVA is actually redesigning our entire ER. It's about a $200 million ER expansion. So my chair is very excited to have any input he can to think about how to make that as optimal as it can be. And the students really enjoyed deeply just doing basic stuff, going around, seeing what the patient experience is in the ER, and trying to feed into the architectural process as best they could, which, again, they were thrilled to feel like they were having a real impact on a current issue at UVA. But the cool stuff is the stuff I do my best job to do. I'm the classic kind of innovator. I kind of start doing and then realize I should have been doing a better job to evaluate. I'm trying to get better at that. But along the way, what you can't avoid is just these anecdotes that do come out of the students. Just Corey, in the hallway one time, just kind of blew me away with this quote of just saying how the design program was so empowering to me as a first-year med student, because just the fact that it had been formally allowed to exist sent this message that if I saw something at healthcare that could be improved, UVA expected me to try. I was like, wow, that's amazing. And then similarly, Emily Schutzenhofer, I didn't even know she was doing this. She came back the next fall, and had told me she had gone down to Guatemala and had used explicitly designed thinking methods to improve cervical cancer screening in Guatemala. And it was so effective that the Guatemalan field staff that she was working with, I got this very interesting email, fortunately I speak Spanish, asking, where did you get these IDEO field guides? We'd like 10. And I was like, fantastic, Amazon, we'll get them to you. So that's fantastic. And it kind of leads right into, I've also come to really believe that promoting development of design thinking mindsets, I really do believe, is as important as skill development. Again, you have folks like one of our current students, Sean. He just says these things like, I don't want to be a physician that's resistant to change. The design program offered, the reason I said yes to it was a chance to engage in innovation right from the start of my career. And I thought that was just fantastic. And the way we try to grab that is, the way we structure our program is, again, around these workshops is it's a complicated thing because you only get this once-a-month engagement. The students want it to be amazingly experiential. They also want to learn tons of real skills. They want to make a world impact right away, but they don't have a lot of time. And it's an optimization. It's not a solution. So we're always experimenting with things like that. Our latest experiment was these series of workshops that we hoped might evolve into things that are interesting as individual workshops, but that work as a unit as well. And so we went with this idea of these are each as a workshop theme, kind of seeing like a designer, interviewing like a designer, empathizing like a designer, and prototyping like a designer. And we always also tried to make sure that if a hospital administrator walked in, there was something slightly, at least healthcare relevant going on, so that it was easy for me to justify what was happening. So I'll give you one example. Workshop 3, Empathize Like a Designer, was one of our favorites. Basically, what we did, we took the design challenge of how might we improve the experience of limited sight or blind patients accessing the UVA eye clinic using public transportation. And this is no small thing, just because this is my co-leader, David Chen, standing right here, right outside where you get off the bus. And you have to make this walk. If you can imagine being someone who has limited sight, it's a gauntlet of small, design elements, very small elements in the built environment that it's a really challenging walk. And you have to eventually, the last things, you literally have to make it through this I find this a hard door to manage, and to get in, the eye clinic is just inside that door. So basically what we had the students do is they had to go plan this walk and then in teams simulate being blind and then make that walk. And the goal we really focused on was not, yes, of course, it's easy to sympathize with someone who has lost sight, but that wasn't what we really focused on was the difference between sympathy and empathy. The how might we statement was, you're serving a patient who has a different lived experience, being blind. How could you make that journey better for them? That was our goal. To make that really tangible, we gave them a lot of information about people who do street design to serve the blind. And then we partnered with a local architecture firm that I've worked with for a long time, VMDO Architects, and we designed essentially a journey mapping exercise where we took those data from all their trips, the students' trips, they brought them over, and then they worked hand in hand with architects to essentially journey map, like talking about the emotional journey that they found, like moments, like linking up physical moments on the journey with emotional moments. And just working hand in hand, literally seeing how an architect takes those types of data in and starts to kind of process it, and then started to develop some actual specific interventions that might assist blind patients. And they came up with amazing stuff that we captured it all and actually sent it back to UVA, the Office of the Architect, and a lot of it actually was. They came up with really interesting things from very simple physical environment things, ranging up to really interesting things about, things like beacons. They had this idea of if you had a seeing eye dog, like you could have almost like a dog bones that kind of as you went through, there would be these, you would get information that would kind of use things like augmented reality and stuff to kind of give them the necessary information they needed to make their journey a little bit easier. Students loved it. VMDO loved it. It was great. My final message is what's starting to happen to me now, and Bon is feeling this too, is people get excited and they want to help. So the way they offer to help is to say, Matt, there's an hour in the main curriculum wedged in at the very end of the classroom time, going into clinical time. You can teach design thinking to an entire class, and you have 90 minutes. And my response is, you can't do that. But of course, what I say is, yeah, that sounds great. Let's try it. So I'm in my second year of experimenting, and so here's what it looks like. to try to teach design thinking in this type of experience. But I got to tell you, it's been actually pretty fun. Let me show you with my last little minute or so what I've done. And basically, I stood up there and I said, well, the only way I can do this is these guys are about to go. These guys are about to go into clerkships. I'm like, if I don't, I put this up literally right in front. And I was like, so I recognize if this isn't true, you're not going to listen to me for the next 90 minutes. And I said, so I'm going to try to make this true by the end of the 90 minutes. And basically, I said, so here's really quickly, why should you listen to me? Okay, guys, gunners out there, I know you know who you are. The last 2 years, you guys have differentiated yourself by, we've wheeled in huge amounts of information, and you've done an incredible job by processing it faster than your peers. Well done. Here's the problem. The rest of your career is about collecting patient stories. And so basically, discovering latent information to improve patient care, that's the new differentiator. It means you have to talk to people, and you have to understand what's going on to them and find things they don't even necessarily know is relevant to their care. Turns out, and so remember, though, I was like, okay, well, how do I, that's great. They were kind of like, okay, we'll give you a shot. And then here's how I tried to operationalize that. Essentially what I said to them was like, we can't take on all design thinking, but actually we're going to focus just on interviewing, a different type of interviewing that maybe you haven't learned to do in your differential diagnosis stuff. Turns out it's a central focus of design thinking. And I basically, to Bond's point, I even told them I was copying totally from the gift-giving experience from the D School, if many of you did. But I basically just hooked it a little bit with making it about a hospital care package. How can we redesign the experience of giving a hospital care package? And just made these structured worksheets that took people through a process of interviewing a partner and designing a better experience of giving a hospital care package for them. And the reality is, it kind of worked. It was awesome just to see the students really engaged on it. They get so few times opportunities, not just to do practice interviewing, but weirdly enough, they don't get a lot of opportunities just to get to know their own classmates very well. And when you'd walk around, they were taking this incredibly seriously. The stories that were coming out, they were so engaged. And we've done this 2 years now, and it's both times that this has been the truth. And these really sad, sometimes, stories about a loved one. And they learned stuff about their college classmates they had never learned before. Just really beautiful stories. There were also these hilarious stories. Like this guy was basically like, they were not talking very much. So what's going on? He was like, oh, I don't give care packages. It's too risky. I might give the wrong thing. And so I was like, dude, like, oh, okay, we can do this. So that's the moment that he saw going on. But it was fantastic just to then push them to like, okay, let's start drawing something. What are some of your ideas? Getting some, going through a very fast design process and being able to think visually and so forth. And it was a really fun experience that has been really high rated, and people are excited for us to keep doing it. So that's basically, that's quick 3 lessons I've learned. We've got more information all the time, just like Bond, limited bandwidth team trying to do our best and feel like we're part of something, certainly not leading, but we're trying to contribute to this very exciting time. So thanks very much. Appreciate it.
We have time for some questions. Where's the mic land? Okay, questions.
Yeah.
So, if you don't mind using the mic so we can capture. Okay.
So this is really fascinating. I've worked with a lot of physicians who are Oslerians, so I'm just kind of curious what Sir William Osler does, his concepts, and how that falls in with what you're doing, and what the great improvement is, because it seems like
there's... So I just came out so I just finished doing the talk. I know Osler. What do you feel? How would you summarize the quintessential Oslerian moment, or what's the quintessential Oslerian approach?
Bedside.
Sure. I mean, that's the thing. I actually talk about this a lot. Like, the metaphor we use a lot is the Swiss Army knife. What I mean by that is like the last thing in the world I want one of my students to get out about me teaching this course is that Matt Trowbridge is going around saying like the traditional differential diagnosis, like clinical interview is done, man. We're breaking that out. I was like, no, that's not what I said. it's about having different types of skills so that, like, what I talk about is, like, if you need, the one I always joke about is, like, if there's a trauma or a code, nobody bring their Post-its to that one, please. You know, that's a moment to just, we got to run the process, all right? But, so the same thing, like, when you're just doing your classic clinical interview, that's fine. But what about when something's just not quite clicking, and it could be on the time scale of a 5-minute interview, or it could be a 20-year relationship you have with an internal medicine patient or something. Having a new interview approach that is more about that latent information, where you're trying to pull out stories. I think a future physician, a current physician really, has to be able to switch gears. We have another friend who's a part of this community, Jay Barrick, up at Brown. He's a writer, and he's an ER doctor too. He always talks about, he calls the HPI his first draft of getting to know a patient, and then he goes back and edits. And I think that's another way of thinking about it. So I don't think that part doesn't, to me, conflict with Oslarian. It's more just like it's a new added skill set.
Other questions?
Hi, thank you for this talk. I'm a current medical student here. I have a business consulting background. This is something that I'm very excited about. Do you have or do you know of any plans to implement this kind of teaching nationally in medical schools?
I think that's really what we're working on here, honestly. You know, what's fun, and part of the other reason I get invited back to the dean's office periodically is I collect emails that are starting to stream in, and I think Bond gets them at many more rate than I do, but like literally 2 to 3 med students that are actually not med students, they're prospective med students. They're literally writing me, they're being like, "Hi, Dr. Trowbridge, I saw your program at UVA. It's very exciting. It's actually swaying me towards University of Virginia over other choices for medical school education." And the dean's like, well, "That's actually kind of interesting, actually. What's going on there?" And they want to start. That's where they want me to come be a part of the orientation and stuff. That is that moment where I'm also like, you remember you're not giving me any money yet, so we can talk about that. It is all really, honestly, I think this is something that is that's part of my interest. Is actually while we're preparing for, I think, a very clear future, that transition. There's an innovation in just implementing this stuff right, so that it's doable at a national scale in a right way. I think that's actually what it's what I feel like I'm positioned to contribute to, but it really does help a lot. The only reason I get to keep doing it mostly is that the students keep saying it's awesome, and that they're genuine, and that they keep doing well in their boards, but they're also like force multipliers all over the health system. Like that Guatemala project I showed you, that's a long-standing project, but like my students make up like 70% of their best students right now. Like, literally to the point where the program officer came to me and was like, "What are you teaching these kids?" Like, some of my guys, like the other summer, he brought human-centered design. Corey, it was that same guy. He brought down and basically brought design thinking to redesigning the electronic medical record system for this small hospital in Guatemala. And like, literally, like the place was just blown away by him. And all he was doing was very basic design thinking kind of approaches. So ask for it. Say it would be cool as a student.
And
One last question.
I have a question up here. So this is really fascinating, and my question is pedagogical. It's so interesting watching you take us through various examples of teaching design, thinking and design education to first-year med students. What about, and what would you like to see for those of us who teach at the undergraduate level but have a high pre-med and STEM ratio in our humanities classes? What kinds of skills or thinking would you like us to be thinking about as educators as we train them before they come to you?
I think the cool part is maybe the simplest thing is what I enjoy is that design thinking kind of stays this very simple. It's not a magical thing. It's this what I enjoyed about the conversation we were all referencing about with Dennis last night was hearing the origin of the term design thinking. the idea of design thinking was only, I didn't know this. It was really only about a 10-year-old term. It was really more that IDEO had been doing so much product design, but as they were having success with that, they were starting to be asked to take on bigger things like service designs or policy design, and they knew they needed to have more input, and so they needed a way to democratize the design process, not make it so controlled, and that was really the exciting part. So I guess the point, where I'm going with that is, design thinking kind of stays the same, but maybe what you could do is, you hear, like Bon, myself, I think to do the job Bon and I do, you have to be a master at saying, whoever even slightly raises their hand, you grab them and pull them on stage. So if you have students with bandwidth to take on these things, the health system and public health has unlimited problems for you to focus on that are very meaningful. And I think showing that healthcare is trying to move itself to being open to these approaches, I hopefully can make more students who have see healthcare and a medical career as a way that they could contribute to the world.
Okay, we will stop there. Please join me again in thanking us.
Thank you very much.
Okay, and I'll just mention the design thinking class that I'm